afternoon. Good afternoon, all. Myself, Dr. Kiran Varma, working as head of the emergency Yashoda Hospitals, Malakpet. I would like to take this an opportunity to invite you all for this series of webinars conducted by Emergency Department, Yashoda Group of Hospitals, in association with Society for Emergency Medicine of India and NBI. As you all know that we come up with an interesting topic every week. So this week also we have come up with an interesting and important topic as well. So topic for today is trauma systems for this century. So for any emergency department or any ED physicians across the globe, trauma is the one major chunk. So we are more interested and we have to do a lot more to improve trauma services across the globe. To enlighten on this particular topic, so I'd like to welcome Professor Peter Cameron, who is the Academic Director of the Emergency and Trauma Centers at Alfred Hospital, Melbourne, and Professor of Emergency Medicine at Monash University, and past President of International Federation for Emergency Medicine and the Australian College for Emergency Medicine. He has written multiple edition texts in emergency medicine, and he has researched extensively on trauma, emergency medicine, and resuscitation. His academic group runs courses across Australia and internationally, including India. So with this short introduction, I would like to welcome Professor Peter Cameron. So thank you, Professor Peter Cameron, for your valuable time. Thanks for joining us. So now I would like to hand over this podium for Professor Peter Cameron.
Thank you, and thank you very much for inviting me to speak. I was hoping to catch up with everyone at the MCON meeting, but unfortunately I came to grief with my visa, so I couldn't catch up with everyone. But anyway, here's a chance to have a discussion about trauma systems and where we're at with that in this century. I'll just share my screen. Hopefully this will work. I'm hoping everyone can see that now. Yes?
Yes, sir, visible.
Good. Okay, so just a brief outline, a little bit about trauma systems and the history of trauma systems, a little bit about our experience in Australia and in the UK, and then where we are going to next with regard to trauma systems. So we go back to the Vietnam War. There was, or the American War, as the Vietnamese call it. There was a lot of learnings from the casualties in that war, and they managed to improve outcomes from trauma significantly by, compared with, say, the Second World War or the First World War. The Americans made a big difference to survival by having rapid transport to surgeons who fixed people up quickly, rather than the old days of hours and hours and sometimes days before people were treated. The thing about this was that those same surgeons went back to the US and they started to impact greatly on the way their emergency and trauma systems worked in the US. So the military model was early triage, early evacuation, definitive treatment in less than 60 minutes, and a centralized surgical management approach. Now, I guess the question is whether that military model is in fact relevant to what we see in civilian systems in this century. So Victoria, like many places, that's the state I work in Australia, like many places around the world, introduced a trauma system. It's now more than 20 years old. And like the American military model, we wanted to reduce morbidity and mortality, get the right patient transported quickly to the right hospital, but also look at the patient's journey from the time of injury right through to rehabilitation and a community integration. One of the great features of our system in Victoria has been that we do a statewide trauma registry, which allows us to track the patients right across their journey. So for those of you who don't know much about Australia, Victoria is a relatively small state down the bottom. There's about 6 or 7 million people, most of whom live in Melbourne. But it's still, even though it's small, it's about twice the size of England. But it has an integrated trauma system with a single ambulance with road and air, 2 adult major trauma centres in Melbourne and 1 paediatric. And we have a no-fault insurance for road traffic and work. So if you look at the centres across Victoria, the major trauma centres are in the centre there in Melbourne, and then you've got smaller regional centres, some hundreds of kilometres from Melbourne. One of the things we wanted to do was make it a state system as opposed to just a bunch of hospitals working independently. And one of the critical elements of that was having this statewide monitoring system using data and data linkage with both the ambulance, the births, deaths and marriages, coronial information, and also the insurance systems, and having that feed into the trauma services, to education and system-wide governance. And just another way of demonstrating that. But the point about this slide is that the data was central to driving the changes. So what we've found is that contrary to the military model, what we're finding is older fallers are increasing at a dramatic rate, and they're driving an overall increase in trauma numbers and trauma deaths. Motor vehicles are decreasing, motor vehicle collisions, and most high energy trauma gets definitive care at the major trauma centres. But there's very small numbers of penetrating or trauma, the sort you would see in a military situation. So if you look at the system as a whole, the numbers are increasing. The percentage going to the major trauma centres is staying relatively static, and the incidence per 100,000 population is actually increasing. And when you look at what's causing that, it's these older people, especially the very old, the more than 85, 85 and older group. It does apply a bit to the older than 75s, but it's this really old group that are driving it. And when you look at the young, the ones we get most excited about, pediatrics and the 16 to 44-year-olds, the incidence has been very static and not increasing at all. And when you look at the causes, motor vehicles are trending down, and low falls are increasing significantly. And of course, in a more civilized society, assaults are a pretty low number of cases. One of the things that, again, is different to the military model, we've got a centralised system with long pre-hospital times, and these times are not getting shorter. So the median time, that means 50% of patients will take more than an hour to get to the major trauma service. And the 90th percentile is an hour and a half. So these patients are taking, the golden hour is long gone by the time they get to hospital. If you look over the last 5 years, we haven't had any improvement in trauma deaths. So it's been static. That was contrary to when we first introduced the trauma system, where we ensured that the right patients were getting to the right hospital and getting the right treatments. We had about a 50% reduction in adjusted odds of death. So we had over the first 10 years of the trauma system, we had a fairly dramatic reduction in adjusted odds of death. But then the last 5 years, there's really been no change. And importantly, along with that reduction in deaths, we also had an improvement in disability over that initial period of time. So not only were we saving more people, they weren't being saved to be disabled, they were saved to be functioning members of society. If you look at deaths trauma deaths as opposed to numbers going to hospital, one of the things that's sadly in our society is that hanging is the second largest cause of death after falls. Remember that the falls are mostly old people. The hanging are suicidal and mostly young. And transport related comes after that. Firearms and other injuries are much less common. So with mortality, you can see that the percentage that die in the older than 85 group is around 35%. So this is 35% of the in-hospital trauma deaths are due to that group, and about 20% are due to the 75 to 85. So they make up over 50% of the trauma deaths. Now, just moving on to post-discharge, because this is often not well described in other jurisdictions. It's something we've been meticulous about tracking, is what happens after they leave the hospital. And we look at outcomes, particularly the EQ5D, the HUDAS, which is the disability score, and then the Glasgow outcome score, pain and return to work. We also link with the births, deaths and marriages, traffic accident, and with the Department of Health to get admissions data. So we have a fairly comprehensive view of what happens after their discharge. Because we've got that data, we're able to show that the trauma system, when it was first introduced in the first 10 years, resulted in a significant reduction in cost of injury for the state. The billions of dollars that were saved were actually resulted in improved insurance payments for compulsory third party. Interestingly, when you look at what predicts bad outcomes, as expected, mobility obviously is worse with increasing age, but lower level of education and claiming compensation for injury actually, so paying people, effectively paying people to be sick or injured results in worse outcomes. Now, from a humanitarian point of view, it's a good idea to help people while they're sick, but the downside of that is it actually results in people being slower to mobilise, to self-care, to get back to usual activities, even increasing pain and discomfort and anxiety and depression. So it really affects all domains of recovery. Obviously, increasing age is generally bad for recovery, but it's actually the opposite for anxiety and depression, in that younger people tend to have more problems with anxiety and depression. But lower level of education also results in poorer outcomes. So we also run the Australia-New Zealand Trauma Registry. It's right across Australia now, and we collect a more modest data set because it's much more difficult doing it right across Australia. But nevertheless, it does give us a bit of a handle on what's happening right across Australia, and we can now benchmark hospitals across Australia and New Zealand. We usually compare things like risk-adjusted length of stay and mortality, and use funnel plots to display that. The TARN, the UK registry, which is well established and has a great track record, has a much more extensive list of quality indicators. One of the problems with having such a big list is trying to make sense of all those indicators. And of course, one of the problems with quality indicators is how they're used. So it's all very well to have many quality indicators, but when you actually look at these indicators, what you find is that the patients who do worst actually do best on the quality indicators. What I mean there is that a very sick patient will generally get to theatre fast, they'll generally have their CT fast, and they'll be generally get through the system fairly rapidly. So these time-based indicators are generally very good on the very sick patients. And so when you look at risk-adjusted outcomes for those patients who fail indicators, they generally, as I say, the patients generally do better. But there are a list of indicators that are tracked in the UK. We don't track those in Australia. We tend to look at individual cases. As I said, one of the problems is that these indicators don't correlate well with outcomes, and there are perverse actions when these KPIs are used in a heavy-handed way, and that people effectively push patients through, sometimes to their detriment, rather than using clinical acumen. But it is useful to have clinical indicators to look at. Presentation of data is critical, and it helps to get clinicians on board. As I said, we use funnel plots extensively because they take account of volume. Caterpillar plots are used in the UK quite a lot. That's the funnel plots, and variable life adjusted displays are also used. All these are ways of engaging clinicians and making a sort of pictorial representation of the data. So we've got all these data over the last 20 years. Can we use the data better? Most hospitals now are using electronic medical records. These represent significant opportunities for us to improve the use of data and get more real-time data. The other thing with the EMR, it does give us the chance to use machine learning and artificial intelligence, and even things like data-driven approach to test ordering. So the way which scans you order, which blood tests you order, and so forth. You can use machine learning and artificial intelligence to check that people are ordering the right scans for the right patients. The linkage between databases is technically much easier, especially for post-discharge comparisons. The UK does this exceptionally well with their sale of the secure anonymised information linkage. We've also now got a secure data platform called SERP in Australia, but this allows linkage in a secure environment without data hacking. So the technology now has improved significantly to allow, the matching between databases. And of course, image transfer protocols mean that we can now manage patients remotely. We can look at their CT scans. They can be 500 kilometres away. We can review their scans and say the patient can be managed locally or needs urgent transfer. The decision support is a two-edged sword, and we've been playing that with this now for some years. But we can use data to guide decision support real time, using past experience. But the virtual management, I think, is really taking off. And this is really important where you have a centre with expertise, a major trauma centre, and you have patients that are 200 or 300 kilometres away, or even 50 kilometres away. They can be managed virtually, with iPhones, with image transfer protocols, with access to results, all these sorts of things. We can actually manage these patients pretty well in a secure environment. And COVID gave us a chance really to trial virtual management, and I think there's going to be significant advances in this area. And of course, just your own car now has more advanced technology than what we use in the resus room. I'm not sure why, I do understand why it's expensive, but really we should be using this more, in terms of physiological monitoring, results. All these things could be immediately available to us in the resus room, rather than having to go back to a desktop computer or watch something on the wall or whatever. I think we can do this a lot better. And with the abnormal physiology that could be alerted to us whilst we're working on the patient. And this is not only in the resus room, this can be pre-hospital as well. We do have new technology now. We've got better diagnostics. The CT scans are so much better. The bedside ultrasounds, imaging is just a whole different level. And with that has come interventional radiology. And the role of the surgeon now is fairly limited. We look at all our major trauma patients, and less than 5% of them require a abdominal or thoracic surgeon. I mean, we still use hammers and nails for the bones, but the truncal surgery now is very limited. Even with grade 5 spleens, they will be embolized via IR, and so we're really looking at a very different approach to a shocked trauma patient. The donut of death was what we used to call it when I was starting out, and now we call it the circle of life, because we identify where the bleeding spots are before the intervention is done. And in fact, if the resus room is set up the right way, this can be done in situ in the resus room, a hybrid resuscitation room. This is where the more advanced centres are going. So the trauma centres may be more about coordination and less about a rapid transit to a surgeon sitting in an operating theatre waiting for that patient to get there. As I said, more than 95% of the patients do not require urgent surgery. Many of them will require orthopaedic surgery, which is obviously not urgent. And then what the trauma centre and the trauma expertise should be doing is coordinating the system so that these patients get access to high-level expertise, but not necessarily in the hospital that's called the major trauma centre. And setting that up with the right governance, the right follow-up is all possible, but it requires centralised governance and coordination and excellent data to make sure that you're actually improving outcomes. And just recently, we wrote another editorial which really making sure that we're treating trauma like a disease. We're not treating trauma as a single surgical intervention. So yes, we can tie off the knot, we can stop a person from bleeding, but actually what's important is that trauma doesn't happen at random. It happens to certain people. We've found that if you look at, given that many of these patients are older, and many of the patients are from falls, and many have comorbidities, we've introduced a 24/7 allied health model of care and shown it to be cost effective by getting the physio, the OT, the social worker, identifying the various syndromes early. We can get the patient out more quickly. They have less time in physical rehab, and they have better outcomes. So we think this is going to be very important going into the future. And if you look at, as I said, trauma does not happen at random. It happens in younger people, people with psychiatric conditions, to take drugs, risk-taking, homeless. The odds of having a major trauma incident are significantly higher for homeless people, for lower educated people, for poor people. And if you have like 2 or 3 of these conditions, the odds go up to something like 30 times the odds. So a wealthy person in a wealthy suburb who has no problems is actually really unlikely to have major trauma. In the older age group, the trauma can be part of frailty and terminal decline. And so if you think about the various syndromes underlying trauma, you can make a difference to obviously preventing the trauma, but also early interventions to prevent recurrence of trauma. So I guess the point I'm trying to make here is that to make the trauma system work, you've got to have data to drive it. You've got to have a governance structure that allows the interplay between the pre-hospital, the different levels of hospital across the region, and then obviously recovery, rehabilitation, recovery. If you're going to use data well, we need to move more to real time. And I think the databases, the data platforms are getting better, and I think it's getting cheaper and more feasible to do this in real time. Most clinical databases haven't kept up with the data science. And I think if you're talking about expertise, clearly the people at the major trauma services see a lot of patients and they have a lot of expertise, but it shouldn't be confined to the trauma centre. If you turn up to a secondary centre, you should be able to access that expertise and use it real time with real input from these experts. I don't think the military model that we had from Vietnam is really fit for purpose. I think we need to adjust our thinking a little, because it's not about surgery. Surgery plays a small part in trauma now. And so I think there is we need to change the current paradigm for clinical decision making. And I think we do have the tools, but we need to get them all to come together to make sense of it. Thank you very much, and I'm interested to hear questions or thoughts from you.
Yeah, thanks, Professor Peter Cameron, for your talk, for enlightening on this particular topic. So, as you said, trauma is a disease. It differs from one person to another. Then the complexity of the cases will be varied from person to person. Then it's a complex, we can say it is a complex disease. It's not a straight case as well. It's a complex. You have to involve multiple people, as I said. Then the things what you spoke about, like Victoria State trauma systems, as I said, was correct. Then, in fact, we are not using military mode, which is not going to serve the purpose at this point of time. Am I right, Professor Peter Cameron?
Yes. Yeah, you're exactly right. I think what you say is correct. The patients that we see now are often have a lot of underlying conditions. So just to patch them up and stop the bleeding is not really treating the patient. You're treating a certain part of the problem.
Yeah, true. Then you discussed about quality indicators. That is very, very important to maintain the data, all those things. Then how to analyze, especially on TRM. Then we need to have data. Then you have to analyze. You have to do a lot more research. So for future development, so it's really good. So in fact, we are lagging such kind of system in India. So there are multiple systems. We don't have proper collaboration. It's like public domains and government setups and private sectors. So we don't have collaborative kind of things. If we are going to collaborate all the systems, it would be beneficial for every one of us. Then it gives more of valuable data. Then we go out with the data. We go out with the research on further. So then, like you said, that early involvement of allied health interventions. Then one thing I would like to ask you, Professor Peter Cameron. So how frequently do you use interventional radiologists for the cases of trauma? So where and all do you use? What kind of cases, especially related to trauma?
Yeah, so really it's evolved over the last 15 years, I guess. So going back, say, 20 years, most cases with ongoing bleeding, no matter where it was, you'd make a decision, you'd have to take them to theatre and tie off the knot, or it was a venous ooze with retroperitoneal bleed or something like that. You would put them in the intensive care unit and you'd give them clotting factors and stuff and hope that they would settle down. And of course, in conditions like pelvic fractures and retroperitoneal bleeds, that was not always the case. And I, vividly remember cases from, 20 years ago where patients basically oozed out over 24 hours. That they didn't have a nice spleen that you could take out, or a tear that you could tie off. So what's happened now is that when we do the CT scans, we see whether there's a blush indicating bleeding. If there is a blush, whether it be in the spleen, the liver, retroperitoneal, in the pelvis, then that's an indication for immediate interventional radiology, and they're on call 24/7 to come in and do that, a bit like the old trauma surgeons. So, as I say, with patients with ruptured spleens, in the old days, we just, unless they were very minor, we would just take them out. Whereas now, it's very rare for a spleen to be removed. And in fact, if they're in a peripheral centre, like a regional centre, we would generally prefer to helicopter them to the major trauma service to get the interventional radiology, rather than lose their spleen. The problem, of course, is, you wouldn't want them to bleed out being transferred. So it really does require good coordination between centres. You can't have them lying around for hours and hours. But if you can get them to the interventional radiologist quickly, then generally you'll end up with a better outcome with these patients. But yeah, it's not just spleens. Basically, even as I said, retroperitoneal bleeds, pelvic bleeds, these are all open to interventional radiology.
Yeah, thank you, Professor Peter Campbell. So even in India, so we have, especially in Yashoda Group of Hospitals, have been utilizing interventional radiology services. So whenever it is required, then so even we have 24/7 interventional radiologists across all 4 branches of our Yashoda Group of Hospitals. So I think there are a number of cases where we have utilized their services. So we have seen one thing that when we utilize interventional radiologists on time, so we can see the good progress in any kind of patients. So that kind of thing we are seeing, we are witnessed multiple times, where we utilize interventional radiologists on time, then we stop the bleeding, then it would be helpful for further registration, then prognosis, everything. So that is one of the nice concept of utilizing interventional radiologists in trauma-related cases.
One of the NHS consultants, Dr. Girish, is waiting to speak.
Yeah, okay.
Dr. Girish, you can.
Hi, Professor. I'm Girish. I'm one of the trauma team leaders working in southwest of England. And I actually work in a trauma unit and work in trauma center as well on regular basis. So how does your skilling network, like for the peripheral centers, how do you manage the skills among the emergency consultants or emergency team? What are the strategies you implement so that the skills are not lost in the smaller centers?
Yeah, I think that's one of the big challenges for all trauma systems. It's even in the major trauma centres, the number of critically ill patients is actually quite small. So your exposure to a shocked trauma patient as an individual clinician is not that great. When you go to the peripheral centres, they might see one a year. They might see a number of major trauma patients, but the number that are critically ill and require rapid resuscitation and intervention is very small. So the answer is we do training, trauma team training at those centres. Obviously, we run EMST course, which is the equivalent of the ATLS course, and then we offer online support for those centres, so that if they're trying to make a decision about whether to transfer, what the next step should be, the trauma services do provide virtual support across the state, and I think that has become a lot more coordinated over the last 10 years. It's still not where it should be, but it's getting better. The ambulance, for the high-speed motor vehicle crashes and stuff, they will generally bypass the smaller centres. So more than 90% of the major motor vehicle traffic will go to for adults, go to the 2 major trauma services, mostly directly and by helicopter. But that's that's not to say that all the patients will get there directly, and so they might have to use one of the peripheral centres as a staging post. So there is a statewide education program. We have statewide grand rounds. We have the monitoring system. We provide feedback to the centres if things don't appear to have gone according to guidelines. We have statewide guidelines. but nevertheless, if you haven't seen a trauma patient for a year or two and they're shocked and they're going badly, it is very hard, and that's where I think the virtual support is quite important. I also work at the Alfred, but I also work at a small centre which is 300 k's from Melbourne, and we had a case that was critically unwell, and we had to make a decision about whether to transfer or not, and so we got the retrieval service. They patched in the surgeon, and the local surgeon was happy to do the operation, but the anaesthetist, who's a GP anaesthetist, wasn't. So we talked that through with them, and the right things happen. But so it is possible to do that sort of coordination, but it's as I say, it's if you haven't seen something for a couple of years, it is quite frightening to see one of these critically unwell trauma patients.
Yeah, thank you very much. Yeah, so yeah, it is a challenge, but luckily in UK, what we do is we get ED consultant from various departments who is interested or have subspecialty interest in trauma to work in trauma center. So that actually helps the coordination linking between these trauma centers to trauma units really well. And for example, I work in a major DGH as a ED consultant and work as a trauma team leader once or twice a month in the trauma center. So that helps a very good coordination between our unit and center, and also gives us the opportunity to keep up to date with our trauma skills. Other setup sounds very much like how you guys do. Thank you very much.
No, that's good. That's good. I guess in India, it's probably more difficult because it's more decentralized in terms of the governance. But I think a couple of the states were trying to set it up in a similar way. Is that correct?
Yes, sir. Some states have taken up it on priority. Like in our state, we do have, for example, on Outer Ring Road, we have some trauma centers set up that are governed by the government has asked a couple of corporate hospitals to set up trauma centers. They are working in tandem with the private sector.
But in India, it is like a complex kind of things. It's not unlike UK, Australia, US, and all. It's kind of involvement is kind of mixed on the public sector, government, and private sectors. Then some associations. It's kind of like that. So what I feel, if you have a platform, so where all people sit together and put their data into it, if they do research a lot in it, so it helps a lot. It would helps a lot to render the better services in the future. So hopefully with this thing, we'll try to implement certain things in our trauma system as well.
Yeah, it's a lot of work to get it set up, and it does cost money. And it, from a government point of view, investing in data doesn't seem like I don't think you win many votes by saying you've got a great database, but it is a fundamental building block to a trauma system.
So can we take any questions if we have any, sir? I think no more questions. I think so. Dr. Girish has asked multiple questions. I think clarified it. Naveen, sir, any other questions?
No, I think Dr. Girish has raised his hand again. So, Doctor, do you have any more questions, Dr. Girish?
Yeah, it's not a question really. Just wanted to say, because I worked in India as well, so I understand the complexity around governance. There is absolutely no fixed or clear governance, out of my understanding, which is regional, which means state-wise or national-wise, to collect any sort of data. Like TAN picks up every single data from here, or even in Australia, they have got their own system where they collect all the data which fits into the TAN criteria. But in India, the problem is, I think there is no mandatory data portal. And as Professor said, it is cost, maintenance, and continuity of that data collection is the key to get the correct statistics in the states of India or entire country. So which it should be a government initiative to collect all that data, which may or may not happen in the circumstances we live.
True, Dr.
Thank you.
Giri.
That's it.
We do accept it. We do agree for it. It's very difficult to get data here. So you name it, trauma, toxicology. So it is very difficult to get the data. So without data, we are not going to analyze anything. If there is no analysis, there is no point. So we are at the initial stage of getting data, collecting data, maintaining the data. So it is big pressure, no? So we need to get out of it. Somehow need to get out of it. We have to collect the data and pull the data and analyze it. It should be, as I say, it should be like a government initiative. Otherwise, it will be like of no use.
True.
So anything else, Professor Peter Cameron, would like to tell something about how we go about the trauma and the future trends in the trauma as well?
Yeah, I think the main points I was trying to get across are that, you know, I think with the way trauma epidemiology is going, the military sort of model of and surgical model of trauma is not fit for purpose for most of the patients that we see. So, you know, the older frail patients, the patients with multiple comorbidities, most of them can be managed in the peripheral hospital with virtual guidance. They don't need to go to a major trauma service, but you do need systems to support the peripheral centres when you have a very sick patient who needs intervention, whether it be interventional radiology or surgery. You need to have a system of care that enables that to happen. And that needs to be at a state or regional level. It can't be just one hospital in isolation, you know, like say AIMS, just as a sort of standalone unit. So I think politically, I think that's a little bit tricky. But certainly a couple of the states were going down that route. I know Dr. Srinath was involved with some negotiations around that. But yeah, I'm not sure politically whether the motivation is there.
Yeah, so no questions, I think. So, thank you, Professor Peter Cameron, for your wonderful talk and for your insights regarding trauma systems for this century. I thank Dr. Srinath sir for creating such a wonderful platform to impart clinical knowledge across many physicians across the globe. Then I thank SEMI Board and Envoy for your association with our webinars. And I thank Yashoda Group of Hospitals for supporting in each and every aspect of this webinar series and all. Last but not the least, all the viewers of our webinar. So thanks for your support. Thanks for everything. So I think with this, we are going to conclude this session for today. Then we are going to catch up in the next session. Thank you. Thank you, Professor Peter Cameron, once again.
Thank you.